And good morning. You have the most seasoned oncology pharmacist, that's like code for oldest, to talk to you this morning about the chemotherapy safety and chemotherapy policies. I've been an oncology pharmacist for 35 years now, a long time. I predate Zofran, I like to tell my pharmacy residents, which is hard to believe. Right now, I'm manager of the pharmacy oncology service line, and I really have the privilege of working every day with our clinical oncology pharmacists, including Mike, who I would like to do a call out right now for all the work he's done to put this course together for years now. He does a great job with this. So we're going to discuss just a few general medication safety principles to bring those back to top of mind. I'd like to review some specific chemotherapy medication errors that kind of led to where we are now, identify some safe practices. I will very briefly discuss our HEROES safety system at UW, and then reviewing a few chemo-related policies, all of this in about 30 minutes. So we'll see how that goes. Of course, a medication error is any error that occurs in the medication use process. And we think of it often as dispensing, but it can be in patient information, it can be in how we label the drug, it can be environmental factors, staff competency, prescribing, it can be anywhere found in the process. So how do medication errors happen? So this is the old Swiss cheese model of failure. And sometimes the lines, despite all of our layers of defense, like CTOE, standard core treatment plans, chemo competency, and independent double checks of chemo. Sometimes all the holes line up in the Swiss cheese and errors do get through. The more layers that we have and the stronger the layers, the less chance there is that an error will actually reach the patient. But we know that there is no perfectly safe system. Our systems do still depend on people, and people do make errors. So back in 1997, when I was a young oncology pharmacist, Klassen and group reported adverse drug events, including medication errors back then, increased length of stay by an average of about 2 days. And various authors have reported that about 50% of serious adverse drug events are preventable. The FDA continues to receive more than 100,000 reports every year of med errors. More than 7 million patients in the US are impacted in some way by med errors, and about 10% of all hospital patients will be subject to a medication error, which I think are kind of scary statistics. So chemo errors can range from just incomplete orders to life-threatening errors. And from what we can tell, and the evidence is not great, studies are hard to do in this area, but chemo errors occur at about a rate of about 2%. They affect anywhere from 1% to 3% of adult and peds oncology patients, and they occur at all stages of the med use process. Oral chemo use is a particular area of growing risk, and Jason, a little bit later, will tell you about some of the safety things we've put into place to try to mitigate this. So why do we focus on chemo safety? Certainly medication safety concerns are not unique to any drug. So again, what is so special about oncology? Of course, as you know, anti-neoplastic agents have the lowest therapeutic index than for any other class of meds. Subtherapeutic doses can cause harm, right, if we don't treat it sufficiently. In chemotherapy, the dosing interval, and the route may vary significantly as a function, of course, of the specific tumor type and stage of the disease and how we're using it. An example I like to use is that a normal dose of methotrexate can range from 10 milligrams for an intrathecal chemo dose to 20,000 milligrams for osteosarcoma. Total doses and infusion durations of 5-FU for colorectal cancer do vary across regimens, even for the same stage disease. And cytarabine dosing varies widely depending on the indication and the length of the infusion. So these were the ISMP best practices for safety in 2021. What kind of concerns me is that they still have the vinca alkaloids in there being inadvertently administered by the intrathecal route. accidental daily dosing of oral methotrexate that was intended to be weekly administration, missing or inaccurate patient weights and mix-ups between metric and non-metric units when measuring and documenting weight. We still have this thing between pounds and kilograms. And a lot of these do still affect our oncology patients. This is just an example of some of these selected chemotherapy medications and errors that are still occurring. And you can see that some of these are horrible and did cause death to the patient. We really need to pay attention to, what we're prescribing and to who and what the patient specific factors are. This happened back, I don't know, I had been in oncology pharmacy, I don't know, maybe 4 or 5 years when this happened, and this really changed our practice. So it was actually at Dana-Farber, and Betsy Lehman, who was a health columnist, and Maureen Bateman, who was a teacher. This is back in the day when we did autologous stem cell transplants for breast cancer, which obviously did not work well at all, but they were prescribed and received 4 times the intended dose of cyclophosphamide. So instead of prescribing the daily dose to be given on each day of the 4 days of the cycle, the whole 4-day dose was given on each day. And 25 medical staff, and these were like pharmacists, nurses, fellows, all pretty experienced folk, were involved, and no one noticed the problem until weeks later. And it was actually a research assistant who was going through and making sure things were documented correctly in the research paperwork that noticed the problem. And Betsy Lehman actually died as a result of the error. She died of heart damage. They actually were able to support her through the neutropenia and other pancytopenias that she experienced, but it was the heart, the cardiac stuff that got her. And then Maureen Bateman actually suffered permanent heart damage and died of her original cancer several months later, which is pretty sad too. This really made us look at how we were prescribing chemotherapy and some safety best practices. Later, in 2009, this pharmacist, Eric Kropp, actually went to jail over this horrible story of this small child who was injected with a solution that contained a lethal amount of sodium chloride. So the pharmacy was really busy. It was the kid's last day of chemo. She was going to Disney. The nurses wanted it done quickly. Pharmacy suffered a bunch of automation failures overnight. They were behind. The nurse called down and asked for it to be done right away, that the patient was there. They were hurrying through. They ran out of normal saline in the pharmacy, so they made their own. And they unfortunately made it with a solution containing 23% sodium chloride. So basically the child died an agonizing death. This was awful, but what was really awful is that a grand jury did indict Kropp, the pharmacist, on charges of reckless homicide and involuntary manslaughter. He did go to jail. The father of this child actually became friends with this pharmacist, and they speak together still to this day about what happened and how to make systems safer to prevent this in the future, which is pretty amazing that something good came out of this terrible situation. I think it's just a reminder to all of us that indeed things can happen at really good institutions, and as long as people are involved, unfortunately, it may continue to happen. We just need to make things as safe as we can and to fix systems that are problematic or allow things to get through. At UW, we had 4 serious med errors between about 2010 and 2014 or 16, including 2 ICU stays and 1 acute kidney injury. We did a ton of work on high-dose methotrexate to make it safer here. Mike Fallon wrote an amazing guideline on this years and years ago now. But and I've linked the high-dose methotrexate clinical practice guideline in there. But this is an example of one thing at UW that we did that looked at the systems that were failing us not the people, but the systems, and really improve the system. And since then, we really haven't had, knock on wood, any problems, although we do continue to monitor it. I know Mike Fallon reviews this guideline on a regular basis and makes any updates, that are necessary to make. Uh-oh. So what are some potential causes of chemo-related med errors? So certainly miscommunicated verbal orders, which is why, of course, verbal orders for chemo are prohibited. The total course or cycle of the dose is given daily. Lack of great pertinent healthcare information, such as the current lab data. We have the wrong weight in, the wrong height in. We have interruptions. Who can imagine that, right? Never have interruptions up on the floor in clinic. But that can cause problems during order processing or dose preparation. Use of abbreviations. We do that a lot, right, in oncology. Hyper CBAT, like all of these drugs, that names that mean a lot to us, but may not mean as much to someone who is new to oncology, a new nurse, a new um, resident physician. And also the lack of a proper copy of the treatment plan or protocol, or the article that details the protocol. That's why we have them listed in all of our standard of care Beacon regimens. And then failure to round doses properly to the nearest whole number. So UW Health had a horrible intrathecal chemo error before I got here, so probably 20 years ago, where we gave vincristine to intrathecally. We realized that we did it right away. We pulled it back. We did lactated ringers. Our patient was actually one of the few people that have actually survived it, but he was a quadriplegic after that. Because of that, we have this policy 6.1.3. You can look it up on UConnect, and now cytarabine liposomal is not available, so not a deal anymore. But methotrexate and basically cytarabine are the only chemo agents that can be administered intrathecally at UW Health per policy. Also, hydrocortisone and either normal saline or lactated ringers can be ordered as flushes. But unfortunately, we do still see inadvertent intrathecal administration of drugs such as vincristine and bortezomib being reported in the literature. To get away from that, we now, and this is what is suggested by international safety organizations, we prepare all vinca alkaloids in 25 ml piggyback bags to prevent recurrence of this type of error. You can see it took us about 11 years to get to the place where we put it in a piggyback, which is a little unsettling, I guess. And it presents a struggle for balance between a prevention of fatal errors versus the risk of non-fatal but severe adverse drug events such as extravasations. But we did partner with our nursing colleagues on this, and everyone agreed that we could watch for the extravasation, but you can't really reverse intrathecal chemo given incorrectly. So any intrathecal administration of a drug must be preceded by a timeout. Why this kind of continues to happen, I'm sure you guys all know this, but vincristine is often given in our leukemia regimens at the same time or on the same day as we give intrathecal chemo. So when they were both in a syringe, the vincristine is like 2 mils. It's clear, it looks kind of like an intrathecal chemo. So that's why people would grab the wrong syringe, not read it, not barcode scan it. And this is what happened. And it does continue to happen across in the world, but I haven't really seen a place that doesn't do vinca alkaloids in a piggyback now for a while. So we do have electronic prescribing. CPOE has made chemo prescribing much more safe. However, we do still have sources of error, such as incorrect data entry, error in electronic build. So despite doing all the checks, an error slips through. System designs can be a problem. For example, this confusing chemo treatment plan option presentation. You know, when you're looking for a treatment plan, you're looking in the Beacon lookup, it's kind of hard to tell the difference between some of the plans sometimes. Sometimes workflows happen outside of the electronic build to kind of make things go faster. That is problematic, and we try to look for that and prevent that. We did find that new practitioners, or such as you guys, the fellows, may not learn how to write chemotherapy orders due to an overdependence on technology. So we've varied our training process a little bit and looked at quality assurance. We did, I partnered with a couple of the physicians about 2 years, I think, after we went live with Beacon, so about 2009 or 10. And we actually asked the fellows to give us the doses of like really common drugs, like rituximab, you know, dose per meter squared, docetaxel for prostate cancer, just some common things that we thought that they would know. And there was some problems, so we certainly had gone down kind of in the knowledge of those because we depend on electronic records. There's also the tendency to view it as a task to complete rather than as a tool to safely prescribe chemotherapy. So kind of the video game prescribing, I call it, you know, where you're trying to just get it through. It's right, it must be right, it's in the computer, and you're just trying to get all those red X's to go away so that you can sign the plan. We've also had some really serious copy and paste issues within the treatment plan. In one that I can remember, I got called by an attending who was very unhappy that we had built this bevacizumab, and I forget what it was, maybe, I don't know. Anyway, it was a plan that contained bevacizumab and some other drugs, and he said that we had built it incorrectly and we needed to fix it quickly. And I looked at the plan that he was talking about, and what had happened is they took bevacizumab out because the patient had had some sort of a surgical procedure, and they had to remove the bevacizumab. And then when they put the bevacizumab back in, they copied it to like all of the days instead of just day one. So be really careful when you're copying and pasting things within treatment plans. So moving on to how we deal with medication event reporting at UW. So the HERO system is the healthcare event reporting online system. One of my pharmacy residents actually came up with this name. His name was Haroland. So we thought it was fairly clever that they named the system HERO after him. I believe he won some Apple AirPods for the naming. So the goal of this system is to report medication errors, adverse drug reactions, near misses, and risky situations in order to improve patient care, promote education of professional staff, and of course, comply with accreditation standards. And just a reminder that adverse drug reactions plus medication events equals, the total of that equals our adverse drug events. It is a way to gather information and develop solutions to events that have occurred. We do look at trends with this, like if something happens more than once, and if something happens even once, that we can fix the system to prevent it from happening again. That's what we use this for. It's a transparent means of discussing safety solutions for our institution. So every Tuesday at 8:30, a group of mostly physicians, a few pharmacists, and nursing leaders and patient safety people meet to discuss the serious safety events from the week before. So we look at every single one and grade it. And we're looking at, do we need to do like a root cause analysis on this? Was it that serious? Or is it something that we can do some quality improvement work on? But I do want you to know that behind the scenes, this is being done. It is not a punitive system. We support just culture, which is open idea sharing and discussion, not assigning blame to people. And it's a venue to discuss topics outside of safety. And it's not a venue to discuss topics outside of safety related issues. So we try to really keep on track with these HERO events. So I have seen some heroes written that were like wildly inappropriate and we're just kind of like complaining about things, and that is not what this is for. So every event is evaluated by quality, risk management, a physician, pharmacy, and nursing. Pharmacy if it's medication related. Queries are made into finding the reasons behind the event. A harm score is assigned, system sources of error are analyzed, and necessary changes are implemented, and data is collected and presented. There actually is a dashboard now that everyone has access to that gives us trends in patient safety. Like, are we making a ton of really serious errors right now in medications, or were there a lot of falls recently? So we do use this information, and the HERO system is relatively new. It's a few years old now. And we're just now, we continue to refine it to make it more, the end results more usable and be able to collect more information. So this is how to enter a new event into HERO. You can actually find this information on UConnect. If you type in HERO, a lot of this information will come up for you. So chemotherapy related policies. So we have policy 6.1.1. This is kind of the grandfather policy of all policies. It talks about chemotherapy ordering, informed consent, verification, administration, documentation, and patient family education. It's a very long policy. It has a lot of information in it, and I would suggest that you look up this policy and at least breeze through it so you know kind of what's there. There's no way that, I expect you to remember all of the information that's in there, but there is knowing that where it is and kind of the basics about it, may come in handy in the future. So it does cover prescribing of chemo for both oncologic and non-oncologic indications. And when you look up the policy on UConnect, you will see multiple related appendices and information, such as what Jason's going to talk about in a little bit, oral chemo processes and procedures, emergent chemotherapy. So we do have a chemotherapy cutoff time when chemotherapy has to be prescribed and ready to go. This is a safety issue. So we do understand that there will be times when there needs to be chemotherapy outside of those times, and we've tried to define it there. Appendix A is medications defined as chemo at UW Health, and then just some other things related to this policy. This is the intrathecal chemotherapy ordering policy. Anytime I take this policy for any changes to the policy committee, I usually have 2 attorneys stand up and ask me if there were any significant changes and what there were and how do you support them. The largest payout we ever did as a healthcare organization, at least up to a couple of years ago, was on this intrathecal chemotherapy error that we had. And that was rightly so. And so we do have this policy is considered to be pretty important by the legal consults for our organization. It does talk about what may be prescribed, who may prescribe it, and how it is administered, intrathecal chemo. And that's the end of my section. Were there any questions? I haven't been following chat. You guys all asleep? I don't like it that I can't see you. Nothing in chat? No. Oh, there's Meredith. Hello, Meredith. Thank you. I know that you're here. And Laura. Hi, Laura. Okay, I'm going to turn it over to Jason. Thanks.
Thanks, Mary. Good morning, everyone. So I will take over with some of the discussion this morning. Really, this is kind of going to continue on the same theme. It's not clinically focused per se, but really focusing on kind of key workflows, policies, et cetera, that I think over time we've gotten a lot of feedback to include in this course, just because it's really important to how our cancer center operates. So my background, for those of you I haven't had a chance to meet yet, my name is Jason Bergsbaken, and I'm a pharmacy coordinator here. Been with UW Health now about 12 years, almost 10 years in my current role. Kind of main hats I wear. I do serve as secretary of Chemo Council. So I'll talk about that here briefly. Chemo Council is our oncology P&T committee. So we do all the vetting of the oncology products, chemotherapy, et cetera, for the health system. I also serve as a pharmacy contact to our regional network as well. So other centers that we work with outside of Madison here. I do practice about 30% of the time. So if I haven't had the chance to work with you yet, look forward to doing that in one of our capacities. So I know, again, we're virtual, so it can be a little more difficult to stimulate discussion, but do welcome any questions. Feel free to just jump in if you have anything or additions for those of you that have already insight here on anything I'm going to present. So I'm going to start with Chemo Council. So who we are. So again, we sit and kind of get our authority through the P&T structure at UW Health. So we are one of the subcommittees underneath P&T and underneath the medical board. Again, really with the focus on cancer care and oncology practice across the health system. Our leadership, so Dr. Callender and Dr. Deming serve as co-chairs of the committee. We do have give or take 18 members at any given time. That is comprised of providers. So we have both physician as well as advanced practice provider representation. We have nursing representation. Then we have pharmacy representation as well. We try to have broad representation if at all possible. Not every dot is represented on the committee, but we do try to represent most dots just so that we have specialist insight in terms of all the various business that we're discussing. In terms of our aims, so you can see those listed there. Really, this committee was created and continues to function really, first and foremost to maintain the highest level of patient safety at our organization. So kind of dovetailing on what Mary was discussing. Really, when we think about our processes and everything we do, patient safety is really our true north and our focus. And we want to ensure that all of our kind of workflows within the committee and the cancer center support that. Secondarily, we do want to have a process for transparent mechanism of evidence peer review. So certainly we rely on the FDA, NCCN, et cetera, other external organizations and their review process and recommendations, but want to have ownership here within UW Health regarding what types of chemotherapy, supportive care, and regimens we're offering to our patients. Efficacy as well, of course, is something we consider. This spirit of uniformity. So more and more now we're giving some of these agents and regimens across different disease states, across different areas of the cancer center. So how can we be consistent and uniform in our approach? I think that promotes safety, also promotes efficiency within our overall care delivery network. And then finally, value. So this is our newest aim. This was added probably about 5 years ago now. So this could be its own discussion, but certainly I think everyone's aware of the exponential increases in healthcare costs, specifically in cancer care. So there's an effort to do what we can to try to maximize the value of therapies that we offer. At this time, there's no, I would say, objective measure of, say, something like cost effectiveness or something like that in terms of our approval process. However, we do bring costs forward as much as we can, and I think at least try to empower our providers and whole team when we're having discussion with patients to kind of understand how that value might come into play, both for the overall healthcare system, the organization, and for that individual patient. So I think we've been able to at least help support those conversations. In terms of the work of the committee, really the primary policy that I'll refer you out to is policy 6.1.14. That really describes how we essentially review and approve chemotherapy for use here at UW Health. That policy has a number of kind of different areas. So it talks about kind of our formulary process, how we go about reviewing or disapproving core, which is kind of synonymous with standard of care protocols or patient-specific requests, how we look at certain guidelines that might, be impactful for oncology populations, and then kind of our ancillary tools as well. So this schematic essentially is a pretty good summary of our core or our standard of care process. So essentially, really as a high-level summary, there is kind of a form that we utilize. So once we're notified by a provider within a DOT that there is a new regimen, new agent that there is interest in moving forward as a core standard of care, we complete that. That ultimately then does go to the committee for approval. We've aimed, and each DOT operates a little bit differently, but to try to increase the transparency across DOTs in terms of these requests. So, if we have one specific provider that might be championing a new protocol, to send that out. Each DOT operates a little bit differently, some more electronically, some presenting it at a DOT meeting, just to ensure that there's transparency across the DOT provider team of kind of new regimens that are coming through. It also allows us the opportunity to get consensus from the DOT in terms of where we see this being used here at UW Health. So at times that might be as simple as the label or an NCCN recommendation, but at times there might be kind of more nuanced recommendations that we might feel positioned to place on a regimen in a specific population or a specific line here at UW Health. We do as well. So we recognize that, as a tertiary referral center, NCCN center, we see challenging cases and patients that, may not have a great standard of care option. So partially because of that, there is a patient-specific process that does exist. So back to kind of the spirit of safety that I mentioned before, the committee wants to have the ability to essentially review primarily for safety, but also for efficacy as well. If there is a regimen or agents defined as chemo that are being used outside of a standard of care, process or standard of care use. So that's really what this process allows us to do. So this is really done predominantly electronically within the committee. There is a form as well that the provider or team will fill out. That can be sent to me, and then I will basically send that out for an electronic review to the committee to essentially, again, attest that we have kind of documented safety and efficacy to move forward with this approach. There is a couple of criteria that we ask for. So essentially, some rationale in terms of why this is being pursued, why the standard of care option might not be, available for the patient. We do ask that agents that have, say, a non-formulary status first come through our formulary process. Really, the reason we do that is, as you might imagine, for all of these drugs, there's a lot of behind-the-scenes, like health link type of operations. So there's a medication record that has to be built. There's a protocol, which again, all support kind of the safety of use for that agent. So to really, I think, encourage DOTs and providers and teams to be more proactive with submitting, new agents or agents that maybe we hadn't used in the past, and we really ask that we go through kind of that formulary process first. That's kind of why that's taken on there as well. This generally takes about a week, though. Again, it's based on clinical scenario. If there's a patient that's in dire need of therapy, that would be impactful to their overall outcome, we can certainly turn these around, in a day. But we do ask that, we try to get lead time when at all possible to kind of, again, support the safety of all the steps that need to occur. and this is kind of more as well. And the only thing I'll call out here is, and I'll talk about this at the very end, is this process is not one and the same as our fiscal process. So the prior authorization kind of insurance screening process is completely separate, and a approval by chemo council in a patient-specific setting does not necessarily, mean that the patient could get treated on the prior auth financial side. So they're separate processes. I think we have seen in the case of certain kind of commercial payers, we do get to say maybe a peer review process or appeal process. There may be scenarios where, providing kind of justification that we had a peer review committee of experts look at this and support this for use at UW Health can sometimes contribute to our argument, again, in that type of process. But again, it's not a guarantee. So we kind of do all we can to tackle that piece as well. And I'll speak very briefly on that at the end. So I did want to point you to our resources for Chemo Council as I kind of wrap this up. But there is a website linked here. If you type in Chemo Council in the Uconnect hub, first hit should be our resource center that houses our forums that I alluded to. So our core or standard of care forum, as well as our patient-specific forum as well. I did want to call out a couple of other processes that are kind of aligned with the overall Chemo Council work. So we do have a triennial process here at UW through our DOT structure. So what this means is that essentially all of our standard of care regimens that you'll see built into Epic, Beacon, do go through a review process at least once every 3 years. So we essentially take all of the DOTs and they go through in 3-year cycles. So one year is typically most of our hematology and transplant cellular therapy work. And then the other 2 years, we essentially split the more solid tumor DOTs. So that process is led in kind of collaboration with our Beacon team, pharmacy, nursing, and then our providers as well, to basically look at what the kind of portfolio of regimen is within that DOT. Is there any regimens that no longer should be standard of care here at UW Health? Are there any regimens we want to add? Are there any supportive care monitoring types of changes that we want to make across the library? So depending on your role, you may or may not be involved with that process. Then finally, this probably could have its own slide these days, but drug shortage management. So this has gotten a lot of press over the last 6 months, most notably recently with our platinum shortage across the country. So I think as everyone's acutely aware, we continue to have challenges for a variety of factors in our supply chain across the country, most notably recently with our many of our generic chemotherapy injectables. Because of this, unfortunately, there has been scenarios where we have had those threats in the supply chain have come to a point where we, in the case of the most recent platinum shortage, based on our supply and kind of our utilization, we're not able to kind of keep pace. So we do have a policy, and that policy actually based on our platinum experience is currently undergoing revision. So I do expect that to be shared for feedback with the divisions within the next month here. But essentially that policy will outline kind of the steps that we take as an organization, all the way from, a surveillance type of approach where we're just kind of, monitoring things to conservation where we're trying to actively save product to allocation where we do not have enough product on hand to treat our populations and how we would go about allocating or prioritizing that drug. So ethics, as you would imagine, legal and risk management are all involved in this, and this is kind of through our P&T structure. So I'm optimistic that the revised policy will provide a lot better kind of guidance, again, based off our platinum experience, because unfortunately we don't believe these challenges will be going away, just given some of the supply chain challenges. So with that, I think that was going to transition to oral oncolytics. I was going to pause here if anyone had questions about Chemo Council or comments, drug shortages, anything I can speak to. All right. We'll keep moving forward here. So oral oncolytics. So I know everyone's aware of kind of the changing landscape here in cancer care. Of course, we've seen over the past 20 or so years really an explosion in the amount of available oral oncolytics to treat our various malignancies. Extremely exciting, new targets, new therapies for patients. Um, but it has created some kind of different challenges, in our processes as well. And some of those I've listed here. So certainly we've already touched on, cost and access and kind of some of the potential high out of pocket uh, costs that these patients may incur. Some of these drugs are complicated, based on their dosing regimens. And notably, those regimens are now, transitioned from our clinic setting with our infusional therapies over to more accountability on the patient side. And then, of course, many of these come with a lot of possible adverse effects as well as interactions. So there's overall been this, transition more to the patient to rely on them for some of their adherence and monitoring efforts, kind of in the case of these oral oncolytics. So essentially what I wanted to do is just review a couple of policies, again, or processes specific to kind of what we do in terms of management of oral oncolytics here within UW Health. These kind of have originated against, prior work and kind of gap analyses against a number of best practices, including what's out there from ASCO and ONS. So I'll kind of go through these in these buckets. So first off is our Mary touched on this already. So one of the recommendations was really to have a definition of what's considered chemotherapy here at UW Health. So this is again through policy 611, which Mary briefly reviewed. What I wanted to call out here is that that policy, if you would go to that policy in the appendix A, which is all of the meds defined as chemos at UW Health, that policy is kind of perpetually updated. I think sometimes there's questions that originate is on the oral side, kind of specific therapies, particularly hormone targeted therapies, what would be considered chemotherapy versus not. So I would refer you to that policy. I can give you an example. So, a medication like, abiraterone and enzalutamide used in prostate cancer. Those are examples of drugs that you could argue would have a more hormone kind of mechanism, but those are considered chemotherapy here at UW Health versus a drug like tamoxifen, in a breast cancer setting is not considered chemotherapy. What that means is that there are some kind of downstream repercussions of that from a policy standpoint. So one is informed consent. So informed consent is required for any chemotherapy used for an oncology indication. So in the aforementioned example, again, enzalutamide, abiraterone, we are consenting our patients for those therapies. Tamoxifen, that would not be required. The other piece is the very bottom here, Appendix B. There's kind of some additional requirements for oral oncology drugs that are defined as chemo, including use of a treatment plan and kind of all those other safety things that go along with that. So again, takeaway here, I'd refer you to the overall 611 policy, but just be aware that that does define what drugs we define as chemo here, and then kind of some ancillary requirements for Appendix B for oral chemo. I kind of touched on this, but informed consents must be documented for oral oncology drugs. Again, we consider them potentially just as toxic as kind of their infusional or injectable counterparts at times. I don't have really the time to go into all the detail here, but I did want to just call out that as you kind of go through and get more familiar with kind of the ordering workflows, we currently are in what I'd refer to as a hybrid model for ordering. So what that would mean is we do require a treatment plan to be applied for oral oncolytics, but once patients get kind of into their therapy, for some of those therapies, we do allow refills to kind of go through the med activity, kind of similar to other products. So definitely, we need to have a plan applied. But as patients kind of go through and tolerate those therapies and are kind of further on treatment, it might be possible to have kind of a little bit different kind of refill workflow. We do, and then kind of the last point here, we do allow refills to be added per kind of provider discretion. There are some exceptions to this. So certain products, such as your IMiDs for myeloma and other heme disorders, where we have REMS programs associated with those products that disallow refills. The other kind of exceptions would be, I would say, are very, very toxic agents that we know patients, often are running into issues within the first month of therapy. Again, kind of at discretion of providers more on that side, but those are kind of scenarios where we really haven't in the past been putting refills on those types of products. We do have these dose modification notes. So this is for oral as well as IV. So there's kind of a standard note type in HealthLink. Some of you, I think, have already used this. It does flow to a synopsis report. So I think with this angle of oral oncolytics, it really has allowed us to, say we have a patient that calls in. They're not coming back to clinic for a few weeks, but are having some toxicity. And based on their toxicity, the provider needs to make a change, whether that's holding or reducing that therapy. This type of note is available to really document that, and then again, kind of create that transparency across the entire team. What kind of is the current dosing plan. We do have a prospective review process. I just want to make all the providers aware of this. So essentially on the outpatient side, we have it kind of hardwired into HealthLink or Epic that oral oncolytic medications essentially are held up for verification. So they essentially go to a queue and then they're reviewed by an oncology pharmacist prior to leaving Epic to either our own specialty pharmacy or another pharmacy. That was put into place probably about 8 years ago now. We were a very early adopter of this across the country, but we felt like that really puts it in line with kind of our injectable infusion workflows. And of course, these therapies, can be just as toxic. So it really provides another layer of safety to know that a pharmacist, again, is looking at that prior to leaving Epic. Education. So really our pharmacy team is leading this. The majority of our sites. I think really and again, we collaborate with nursing, of course, who's leading a lot of the infusional education. Really the ask is just to continue to communicate with our team, in clinic. If you have a patient that you're starting on new therapy, thinking about new therapy, I think letting us know, early is really helpful, and we can complete that teach, ideally in person or over the phone if necessary. And then I'll leave you with some tools here. We have a similar portal as well for oral chemotherapy here. So if you search oral chemotherapy on UConnect, it'll take you to that link, and some of our resources, education is available there. So right now, for our education materials, we're predominantly using a third-party resource, which is managed by HOPA, which is the Hem/Onc Pharmacy Group, and ONS, which is the Oncology Nursing Society, of course. So if you go to that link as well, if you ever want to provide a patient, education about an oral agent that you're talking to them with, if you go to that portal, it'll link you out to those materials that you could print out for patients. They do a pretty nice and robust job. They were built off of kind of some of the best practice recommendations. Last piece here is ongoing monitoring. So again, we know that these therapies are challenging, maybe not only in the initial month, but kind of the months to come. So we do have some processes in place with kind of more of our pharmacy workflows where we're reaching out to patients periodically, primarily by phone. We've done a little bit via MyChart text messaging with our specialty group, but we are available. If patients are filling at our specialty pharmacy, they get some sort of ongoing outreach with the pharmacist at least every 3 months. So I just wanted to call that out in kind of our monitoring process. So I'm going to wrap up with specialty pharmacy. I guess I wanted to pause again if there was any questions, comments about anything related to oral oncolytics, policies, workflows. All right. Well, last piece here is pretty operational, but again, there was kind of feedback that it would be helpful to touch on this. So this is really focused on kind of our specialty pharmacy and then some of our prior authorization workflows. So if you're not familiar yet with our specialty pharmacy, we are located out in Middleton. So there's a map there. We're kind of on the west side at our pharmacy services or shared services building on Deming Way. You can see the building hours there and kind of what the facing looks like. This is where all of our specialty medications, so again, oral oncolytics, are sent from. Really, the mail order is, I would say, 99% of our patients are using that. It is a free service. It kind of depends on the patient's location. If they're in the immediate area, next day delivery is typically doable. If they're in a more outlying area, that would typically be another business day. The pharmacy is certified, so cold chain shipping. There's different processes we have in place, whether for heat or extreme cold. So all of that is in place. I think overall our patients find it really helpful. There is the ability to pick up at this site. You can kind of see the building is not really equipped with a drive-through or a retail pharmacy per se, but really the process is patients will kind of contact us and kind of stay out close to the door there, and a team member will run it out. So that is an option for patients. We don't really encourage it just because the way that was configured, but it is something that could be available if it's convenient for patients to pick up out in Middleton. I kind of touched on the management services, but again, kind of a collaboration of our oncology team and our specialty mail service team, really doing a lot of the work for education and kind of the outreach and refill management. Kind of notably with our specialty pharmacy is our prior authorization service. So here at UW Health, we do have a team of primarily pharmacy technician driven that do all of the prior authorization services for UW Health patients. That's on the medical benefit, meaning therapies that are given in the clinic, as well as the pharmacy benefit, which is the take-home therapies. The current process for how this works is essentially after your team does, devises the need for therapy, working with typically the clinic team nurse to submit a telephone encounter to our group. They will go ahead and review that and then take the steps necessary and document that in the referral tab in HealthLink. Again, it's really payer dependent, depending on if it's going to be a very straightforward approval or if it's going to need additional layers or review. We do have our MAP program as well, which is our medication assistance program. Essentially, that is staff that is focused on free drug programs. So it's really common, I think, particularly on the oral side, for patients that might have a high out of pocket. They are the ones that will do the screening to say, okay, does this patient meet the criteria, whether it be financial or what have you, to enroll in this program, and then kind of go through and work with you to complete that paperwork. Unfortunately, those processes are very manual and often take weeks. It really is program dependent and kind of dependent on the response of really all parties involved. But we do the best we can depending on each scenario. I'll also mention we have these repository programs specific to oncology. So that's actually a state of Wisconsin program where patients can donate unadulterated drug back to us, and that can sit in the pharmacy and we can use that for another patient. So that's a really nice option for some of these high cost therapies. So really popular with things like growth factor, or we can also take unopened bottles of certain therapies as well. So it's been really nice that the state has supported that. And if you look at kind of across the country, Wisconsin, I'd say is more progressive in that type of model, which has been really nice for our patients. So last slide here, again, really these things are going to vary in terms of length to approval. So again, it might come down to what the use is as well as the payer. For example, a Medicare patient, we are basically looking at NCCN guidelines, and if NCCN guidelines support that for an in-clinic therapy, essentially we approve that. Versus a commercial payer, and we may have to go through their kind of portal and submit some information, go through prior auth, and that can take days. So really the takeaway here is proactivity. I know everyone knows that that's already been doing some of this work, but really getting these to our team as soon as possible, and our team will certainly aim to support as best as we can to meet that individual patient needs and timeline. So with that, we're coming up on time here. So covered a lot. Again, just to wrap up, chemo console, some of those associated processes. We talked about drug shortage management as well, oral oncolytics, and some of those workflows. And at the end here very, very operational, but I hope you find it useful. Some of the nuggets on specialty pharmacy and prior auth. So, what if any questions